Good morning, good afternoon to everybody. Apologies for that slightly awkward pause. I had a sticky video button. Welcome to our webinar, Safe and Respectful First Nations, Inuit, and Métis Maternal and Newborn Care. My name is Nicole, and I am joining you from unceded, unsurrendered Algonquin territory here in Ottawa. I come from a mixed ancestry with roots in the Red River settlement in Manitoba, in southwestern Ontario and New Brunswick, and right across the pond into Wales. And I am really thrilled as somebody with Métis family to be moderating this session on this incredibly important topic today. I should add, I'm also a mother of two beautiful boys and had the great privilege of having two home births, which were supported through midwifery. So again, this is a topic very near and dear to my heart. I am the Director of Northern Indigenous Health at Healthcare Excellence Canada, which is a new organization resulting from the amalgamation of the Canadian Patient Safety Institute and Canadian Foundation for Healthcare Improvement. As an organization, we're focused on the idea that everyone in Canada should have access to high quality, safe healthcare, and that this includes culturally safe care. We work with partners to deliver measurable, widespread, and lasting improvement in patient safety in all dimensions of healthcare excellence. Today, September 17th, is World Patient Safety Day, which is a day established by the World Health Assembly in 2019 and observed annually on this day. The purpose is to enhance global understanding of patient safety, increase public engagement in healthcare safety, and promote global action to prevent and reduce avoidable harm in healthcare. For World Patient Safety Day 2021, today, the World Health Organization urges us all to act now for safe and respectful childbirth with the theme of safe maternal and newborn care. Everyone should have a safe and respectful childbirth experience, and this includes being able to make informed choices about birthing options and having access to medical and other supports to ensure people who give birth and their babies are safe before, during, and after birth. World Patient Safety Day is a global movement, and Canada is joining the World Health Organization and countries from around the world in a unifying global event. This webinar is also one of the ways that we're participating in the global event while also grounding the conversation in our context here in Canada, which is why today's webinar will focus on safe and respectful First Nations, Inuit, and Métis maternal and newborn care. I want to thank our hosts today, the National Aboriginal Council of Midwives, which exists to promote excellence in reproductive health care for Inuit, First Nations, and Métis women. And they advocate for the restoration of midwifery education, the provision of midwifery services, and choice of birthplace for all Indigenous communities, consistent with the UN Declaration on the Rights of Indigenous People. As active members of the Canadian Association of Midwives, they represent the professional development and practice needs of Indigenous midwives to the responsible health authorities in Canada and the global community. And also Patients for Patient Safety Canada, which is a patient-led program of Healthcare Excellence Canada. And for 15 years, they've contributed to the patient perspective in patient safety improvements at all system levels. Many First Nations, Inuit, and Métis people experience significant health disparities and barriers to accessing care. And this leads to an increased risk of poor maternal and newborn health outcomes. But there are opportunities to improve Indigenous maternal and infant health outcomes. One of those key opportunities lies in improving access to high quality, safe, and culturally safe maternal and newborn care that is closer to home, especially for those living in rural, remote, and isolated communities. Access to high quality primary care in First Nations, Inuit, and Métis communities in Canada can improve maternal and newborn care by helping ensure that it is culturally safe and, very importantly, free from racism. Today, we'll learn more about both the challenges and the solutions from our three speakers. It's my incredible honor to share with you these three speakers. We have Vanda Fleury, who is a Métis photo voice and film artist from Manitoba, and who's joining us today to speak to us about her experience as a mother and a patient. We have Brenda Ipu, who is an Inuit registered midwife and the National Aboriginal Council of Midwives Core Leadership Circle co-chair. And we have Dr. Karen Lawford, who's an Indigenous midwife from Laxall First Nation, Assistant Professor, Department of Gender Studies at Queen's University. And Dr. Lawford was also recently elected to the Royal Society, so a big congratulations to her on that. We'll have time for questions at the end, and thanks to those who submitted questions through the registration process as well. If you do have questions, please add them to the chat, and we welcome questions in English or French. With that, I would like to hand it over to Vanda, who is our first speaker today.
Hi there. My motivation for sharing rests with decentering the systems that undermine maternal and newborn safety, particularly during childbirth. It is important that as Indigenous people, we tell our stories and remember our histories. They become lifelines, allowing each of us to give voice to our personal and diverse experiences. My story explores anti-Indigenous racism, patient safety, and health justice through my relationship with birth sovereignty and midwifery. I'll touch on injustice, empowerment, and intuition as emerging themes in my journey. Central to this is the harm I experienced accessing Western healthcare services for the birth of my first child in 2013 at a hospital in Winnipeg, Manitoba. It was considered a normal pregnancy, and a healthy baby was born naturally at term. But I lived the problems associated with the medicalization of birth and experienced anti-Indigenous racism. I am Métis and my husband is First Nations, and as an Indigenous family, I feel a negative perception towards us directly impacted the quality of care we received. A number of cross-sectional studies highlight the insidiousness of racism and its association with the harm Indigenous people experience in the healthcare system. According to Phillips Beck and fellow researchers, quote, racism is often subtle, implied through actions, attitudes, and lack of consideration to such things as safety and comfort of others deemed undeserving, end quote. I had never given birth before, but I came to the hospital believing I would have space and privacy for my body's physical transformations. I assumed I would be treated with respect by the health professionals. Instead, there was a lack of compassion, my dignity was violated, and my labor a public spectacle. My waters broke at 2 a.m., and by 5 o'clock we were at the admitting desk of obstetrical triage. I complied with the nurse's suggestion to go walking. 3 hours into that, my contractions shifted in intensity. It was a struggle to make my way back to the 3rd floor. I checked in with the nurse and described the changes. She seemed annoyed, and her response was that I'd better get used to it because it was my first delivery, and to keep walking. I was turned away without any meaningful consultation or physical exam. Testing GBS positive, I had a drip attached to my arm, which had a dual purpose as a crutch. I dragged it along the grounds of the waterfront, still walking. It was overwhelming, and I felt a lot of fear. The only private space I could find was a public bathroom next to the local coffee shop. I vividly remember the overflowing trash can. I stayed there a while, needing to ground myself. My body was telling me to push, and in response to that, I felt panic. Had I heeded the call, both the baby and I could have sustained injuries, not to mention the health risks of an unsanitary public washroom. Surrounded by health workers, infrastructure, and everything Western medicine should have had to offer, we were on our own. We tried to get medical attention again, and they finally provided us a curtained space adjacent to the desk. Another 30 minutes would pass before I was seen. I felt discouraged and my resilience was fading because I had the impression that a lengthy process was still ahead. I felt like I was spiraling in a vortex, and the intensity made me nauseous. My husband was timing the contractions at 90 seconds apart, and desperately I told him to advocate for us. He went back to the desk and spoke aggressively to the nurse, outright demanding an assessment. She didn't try and hide her irritation and begrudgingly attached the CTG belt and performed a physical exam. Her tone and demeanor changed drastically as she declared, "You are definitely at 10. I won't ever forget the sound of papers flying and nervous chatter. The doors to the labor, delivery, recovery, and postpartum unit swung open, and the head nurse whisked me away in a wheelchair. Less than 20 minutes later, my baby was born. The team on that side treated us with compassion and respect, in stark contrast to the care we received in triage. There is no universal timeline for birthing, as I went from 1 to 10 centimeters dilated in 4 hours. Every woman's process is different. We never received an apology or even an acknowledgement for the miscarriage of health care. When patient-centered care was paramount, I felt unsafe, invisible, and exposed. And there were long-term impacts. I'd have flashbacks that left me feeling a deep sense of injustice. It transferred to a general avoidance of the Western medical system that I continued to grapple with, coupled with feelings of anxiety when engaging with healthcare professionals. I also became aware of a troubling trend towards maternal health. When I shared what happened, I was met with intimidating responses like, "The baby is safe and healthy, that's all that matters, let it go." Not only did I feel devalued as an Indigenous woman, but trivialized as a mother giving voice to her hurt and anger. Speaking out is necessary to unravel systems of oppression. These stories need to be heard, and sadly, many women have similar experiences. Prevention goes hand in hand with health justice, and I actively pursued alternative terms for my second pregnancy. Anti-Indigenous racism is an experience, and this was in response to the disrespect and vulnerability of birthing in a mainstream system. Feeling helpless was unsettling for me, and locating my power ensured it would not happen again. I felt tremendous relief when I was welcomed into the circle of care at the birth center by a registered midwife. She would be our primary care provider in the prenatal, birth, and postpartum for 2 pregnancies. I evolved as a mother, and our family needs changed too, but I was never rushed during any of our appointments, felt prepared for what came next, and she always encouraged our questions and thoughts, as individuals and as parents. The relationship with my midwife was based on mutual respect, and situating myself within a holistic framework challenged the negative memories from the in-hospital birth. Part of this healing work involved contextualizing my experiences. My grandma Gloria has assisted in over 20 births, and I wondered how it could have been different if I was surrounded by my aunts and other supportive women. It pointed me towards our community and cultural narratives about Indigenous midwifery, my most powerful ingredients in birth sovereignty. I work closely with Grandma, gathering medicines and memories, like the one we cherish about her mom Eva, staying out to dig Seneca root with our Auntie Caroline Lapini. According to Grandma, Auntie was respected for her medicinal knowledge and leadership as a local midwife, and according to oral history, she never lost a baby in all of those years. She wore her commitment to cleanliness on her signature style starched white aprons made from flour sacks. My great-grandma Eva went to live with her in 1923 at the age of 5 and grew up helping with home births. In 1920, Gloria's father was delivered by midwife Mrs. Boyer, who cleaned and wrapped him and then smudged it in all directions with an eagle feather she carried in her birthing bundle. And Gloria's husband, who was born on the Welby Plains of Saskatchewan to the attending midwife Mrs. Bercier. The old cross acknowledging her death also celebrates his life, and etched on the wood are the words, "She was well known as a midwife who brought 400 babies or more into this world." Even when Gloria was born in the 1940s at the Bertel Hospital, no one was around either. But Grandma Eva knew what to do, and in her own words, she helped herself. These Métis birth helpers are the lifelines of our family narratives. Reclaiming the past is mandatory in our struggle to control our futures, and the stories of our ancestors are strengthened by what we share. So to celebrate their impact, I created a sacred space for my children in the walls of a bedroom. It has a ceiling of sage with a variety of prairie plants adorning the walls. The sources are documented in a black scrapbook with ephemera, notes, and pictures, including family snapshots from our ceremonies honoring the kids' placentas. They are rooted by the silver willow on the Minnewaska Creek and another by the oak tree on the hill facing the Assiniboine River at our family home in the Uno Valley. It is symbolic of Auntie Caroline's leather pocketbook with the names of all the babies she delivered, their families, the location, and first-hand knowledge of relevant details. The pages were a written testament to our kinship connections across a triad of communities, from Saint Lazare to Saint Marthe to Saint Madeleine. Some of the Métis and First Nations knowledge keepers in rural and northern communities that I've spent time with recall from the old days small black books with genealogical information, and I'm certain there is a connection. It makes sense they would be authored by the midwives, as they were the ones delivering the babies. The fibers of our ethnobotany project cross-cut generations, and sharing these stories are a personal contribution to dismantling Canada's colonial narratives that ignore or devalue Indigenous women's life experiences. Acquiring this knowledge made it feel like I had an extended model of care that transcended time. It was familiar, comforting, empowering, and nurtured my spiritual health as we welcome baby. We planned for a water ceremony at the birth center, and at 6:30 a.m. when my waters came, I notified my midwife. There was a calm excitement, though I underestimated how quickly active labor would start. I learned from my body, and this time I recognized what that sense of urgency meant. It made for an epic car ride, and I came to the conclusion that not all birth scenes in Hollywood films are sensationalized. Morning rain made the usual 30-minute drive longer, and clocking in at 8:55 gave us just enough time to check vitals, then plunge into the warm waters waiting for us. 6 minutes later, our baby was born. Guided by my hands and the midwife's voice, I heard, "There's a head. When you are ready, you are going to catch your baby." Receiving my daughter was a profound experience, and now a unique part of our shared narrative. The well-being of baby and mom was paramount, and I felt validated and redeemed. Her dad joined us in the water, and we spent the first hour floating and holding each other. Birth sovereignty is both concept and action, through choices about body, environment, care provider, mental health, and even nutrition. It changed the trajectory of my experiences because it allowed me to imagine health justice on my own terms. My ancestral birth work was ongoing throughout those 2 pregnancies, and I was able to connect it with gardening and the roots of Indigenous agriculture. I was deeply inspired by a community formerly known as Cahokia, near the confluence of the Missouri, Mississippi, and Illinois rivers over 1,000 years ago. Quoting Gail Fritz, farming was the prerogative, the responsibility, the skill set, and the spiritual domain of the Indigenous women and girls who nurtured and maintained the fields. For me, it's not about replicating the past, but returning to the meaningful customs and reclaimable sources of Indigenous women's knowledge that enrich our cultural foundations. Like the sunflower, though many people are dazzled by open-face imagery, attention to its curves and lines remind me of the placenta. To harvest good medicine is to reseed these sources of inspiration and build on land-based approaches to wellness. Feeling at home in my 3rd pregnancy, I trusted my intuition and chose to have another water birth, but this time in the safety and comfort of our family home. Fear of the unknown had dissipated, and I would not be destabilized by conforming to a system that had failed us. My midwife explained the risks and benefits, encouraging me to tune into the rhythm of my body with careful consideration of my earlier births. Though it was not part of the birth plan, she shared the fundamentals to keep everyone safe should the labor progress faster than expected. Her demonstration was thorough and memorable, and I do not believe we would have been as prepared otherwise. My midwife equipped me with knowledge and built my confidence. This is health justice. At 5:30 a.m., my waters came with the first of only 5 powerful contractions. I reached out to the midwife and had just enough time to fill the tub with water. Not long after I settled in, I realized I was holding baby in for a 3rd time. Somewhere in my head and my heart, a gentle voice reminded me, "Your body knows what to do." It put me at ease, and I embraced myself, sat upright, and called out to my husband, who knelt beside the tub. Together, we received our baby. Her head emerged, and I told him not to pull, as the shoulders needed to turn naturally. Moments later, the fetal ejection reflex grounded her safely in my grasp, then in her dad's hands for a second catching. I looked down through the water and held the gaze of her beautiful brown eyes. It was unchaotic, there was no panic. We prepared supplies like a thermometer, blanket and toque to keep her warm in the water. Coached well, I kept her high enough for breastfeeding, but low enough to respect the umbilical cord. Our midwife was now on speakerphone and arrived within 5 minutes of the birth, then our doula shortly after. We live on the far edge of the city, and considering everything happened in less than an hour, both made it in record time. And just after baby came, my other 2 children woke up and joined us. I was surrounded by my team. I delivered the placenta, and true to the lifelines in our stories, our midwife interpreted it with attention to detail. My son was captivated by her skills, and she explained to him about the environmental and hereditary effects on its form. He was hands-on and glove-free. I hope more Indigenous boys position themselves as birth helpers as they grow within their families and communities. It was memorable, so much so that when he went back to school, he announced to his classmates that he touched a placenta, followed by the news about baby sister. And with a touch of humor and irony, I found redemption in the walls of another bathroom. But this time it was kept spotless, and a recent renovation resulted in a soaker tub that kept us comfortable and warm. We stayed there for 2 hours, and laughter carried throughout our home. I grew up cloaked in the love and character of family kitchen parties, and I felt that dynamic at our gathering that morning. The midwife was seated by the tub, our birth helper had a chair in the shower, my husband was making rounds with coffee and cookies, my children were happy, and even our little dog was there. We were empowered as a family and in good hands with our midwife and doula. I felt pride and excitement about our return to family-attended birthing. Though I did not want my children present for the birth, I did want them nearby, and the autonomy of a home birth created levels of inclusion. Like to guide her spirit, when the time was close, they joined my husband in lighting a fire on the grounds of our home and offered tobacco. Also, having a doula I could count on in a practical way and trust with our wishes made the home birth a positive experience for all of us. Drawing parallels to Jamie Cedro's community research of Indigenous doulas in Manitoba, she fulfilled the role of a, quote, really good relative. I gave her a humble gift, but wasn't able to compensate her in a meaningful way. She has a young family too, and took time away from them to be there for us. Thinking about recommendations, it would be ideal to have funding that is flexible, secure, and long-term to support cultural safety. Having these programs and other initiatives available to Indigenous families, in person and virtual, are so meaningful. I would also like to see the creation of a booklet, film, or online doorway that opens up to individual, family, and community projects, because our homes are sacred and inspiring spaces. And that brings us to the end of my contribution. Thank you for being here today. Merci.
My deepest thanks to you, Vanda, for sharing your personal story and for your vulnerability in sharing that story of reclamation and connection and birth sovereignty. On a personal note, I can so deeply relate to that feeling of safety of being in your own home. And I'm thankful that you were able to have those experiences and that you shared them with us today. So thank you again. Our next speaker is Brenda Ipu, as I mentioned previously. And I also want to note that we're joined today by the other co-chair of the Core Leadership Circle of the National Aboriginal Council of Midwives. So did want to welcome Claire Dion Fletcher as well, and thank you for joining us. Brenda pre-recorded her session with us today because as we were working through setting up ourselves for this webinar, we realized that there are connection issues in her community in northern Quebec were inconsistent. And so in order to make sure that we knew that everyone would be able to hear her very important words and story, we decided to use a pre-recorded session. I do want to take pause though and emphasize that this is something really critical that we need to consider as a country and as a society in our delivery of healthcare, that connection issues in northern, rural, and remote communities continue to be a significant challenge. So let's take this as a moment to note and learn from that. And thanks again to Brenda for being really helpful and adaptive with us as we figured out the best way to share her important words. And with that, I'll hand it over to my crew to share her video.
Thank you, Nicole, and thank you, Vanda, for your openness and for sharing these intimate moments of your life. There are many things I learned from your story. One, I heard the effects racism had in your first birth experience. Two, I also see how resourceful this made you. Third, I heard the difference midwifery care made in terms of providing a safe experience. As an Inuit midwife, I am always surprised when other primary care providers say, I don't need to take a cultural safety training. I am not racist, and I took all that in my professional training. This is very confusing for me, mostly because we have not been meaningful improvement in the health or experience of First Nation, Inuit, and Métis people, or a reduction in complaint of anti-Indigenous racism in the healthcare system. In fact, the impacts of colonialism on birth in Canada have yet to be addressed across the country. For most Canadian healthcare providers, the history they learned during their health education did not include the colonial story of First Nations, Inuit, and Métis people. Instead, they were taught a Western European model of healthcare and medicine. Many Indigenous healthcare providers, knowledge keepers, traditional medicine people, and elders are adding to that story from their own histories, places, and perspectives. Our voices are gaining attention. However, many Canadians are still unaware that they live in an unjust society and that the colonial institutions they work in, like the Canadian healthcare, systematically marginalize and exclude Métis, Inuit, and First Nation people. Experiences like the story of Joyce remind us of the work the healthcare system needs to do to make healthcare safe for Indigenous people, the first people. So it's good to be here with our partners at Health Excellence Canada, trying to elevate the voices of the people receiving care, learning about what needs to change from the patient perspective to improve healthcare services and experiences. I am from a small town in Inuit, Quebec, where I am living that change, where Inuit midwives provide all of the reproductive health care for the territory. We have been doing this for the last 35 years. We were the first to rematriate midwifery in Canada. We have our own birth centers we call maternities, with local midwifery education programs where we can grow our own Inuit midwives. We provide care and education in our mother tongue, Inuktitut, and pregnant women give birth in their hometown in their own language after years of being pressured to travel south to have their babies. Prior to colonization, many generations of Inuit lived as nomads, traveling across the landscape as they hunted seasonally. In the 1950s, the Canadian government pressured families to settle in permanent communities. Residential schools were implemented, and the colonial project of separating Indigenous families from their children began. Also, many healthcare services, including birth, were only to be accessed in the South, and the evacuation policy from the federal government meant people had to fly out to give birth. Inuit women were sent to Montreal or Moose Factory in Ontario and Quebec, rather than relying on local midwives who had traditionally provided care. The government stated that the reason for evacuation in the 1960s was to improve birth outcomes and reduce complications from communities that did not have hospitals and limited prenatal care. But for Inuit women, the policy turned into increased anxiety, isolation, and trauma. Trauma meaning family violence, sexual abuse, child neglect, etc., or alcohol and drug abuse. Because they left their communities before their due date, and they spent weeks away from their families to give birth in unfamiliar surroundings, tended by doctors and nurses who didn't speak their first language, depriving them of their families. Inuit women experienced increased rates of birth interventions, decreasing rates of breastfeeding, increased postpartum depression, and for some, even forced and coerced sterilization. The local Inuit elders in 1980 shared their observations of the impact of birth evacuation, and they wanted to bring birth back to Nunavik and persuaded the regional hospital to start a training program to train Inuit midwives. Now there are 3 maternity clinics, 4, led by Inuit midwives set up in villages along the Hudson Bay coast. The return of giving birth is a community event. Now only 14% of people's births are outside the community because of concerning health issues. 63% of births are in the residents' own village. 86% attended by midwives, 75% by Inuit midwives. Spontaneous vaginal births are 97%, and there are many studies published. The outcomes for care are incredible. As the NACM co-chair, we want every Indigenous community to have access to primary care. Studies have demonstrated that the distance to care has an effect on perinatal health outcome. Indigenous infants' mortality is 2 to 4 times higher than that of non-Indigenous newborns. Indigenous midwives can close the gap. COVID has highlighted that women and gender-diverse people have been experiencing higher rates of gender-based violence within households, and that measures to control the pandemic have reduced access to essential health and social welfare services, including sexual and reproductive health services. Having Indigenous midwives in every Indigenous community is a safeguard for Indigenous families. We do so much more than catching babies. We provide access to cancer screening, access to vaccinations, testing and treatment for sexually transmitted diseases, provide contraceptions, guidance to our youth around respectful, safe, and consensual sexual relationships. Midwives are relational providers, establishing a trusting relationship with our clients so they can access health care on their terms. It's all about taking the time to share information, creating context for informed decision-making and choice and understanding families' health priorities and meeting people where they are at in your language. It's all about families, communities, creating future generations and healthy people. The significant contribution we make day in, day out is not known to most Canadians and policymakers. Systemic racism is rampant in the healthcare system, especially against Indigenous peoples. We need a more compassionate and thoughtful system which recognizes the important role that Indigenous medical professionals play as clinicians, educators, mentors, and researchers. So as we celebrate World Patient Safety Day, I am really happy to be on this panel with Vanda and Karen, who are highlighting the importance of reproductive and newborn health experiences and outcomes and how they need to be improved for Canada's Indigenous populations.
My deepest thanks to Brenda for sharing the story of the midwiferys in Nunavik and really demonstrating the incredible value of Inuit midwifery and the power of returning birth to community. I often speak of the Inuit midwiferys as this amazing example of care closer to home and of Indigenous driven and delivered care. So my deepest gratitude to Brenda, as well as the National Aboriginal Council of Midwives for working with us on this event. And with that, I would invite Dr. Karen Lawford, our third speaker, to join us. Hi, Karen.
Hello. Hi. Is everything working on your end for the speaking?
You look and sound great, Karen.
Oh, thank you. Wonderful. Miigwech so much for having me here today. I am a little bit nervous because there are people in the audience who I know, so I'm going to take put a timer on for myself. I think that the words that were shared with us today are so deeply meaningful, and they are words that I think many of us have heard before. So in some ways, adding some more depth to our understanding of maternity care that's provided to Indigenous peoples. One thing I heard a few things from Vanda when she was speaking, this idea of compliance, the medicalization of birth, the unlistening and dismissal of her voice, of her experiences, of what is actually happening to her during labor and birth. And she was devalued. And I think that what does that mean? And why does it keep happening? I have a notebook to my right, I'm looking down to. I really want those of you who are here to please encourage, you need to know your history. You need to know that when Canada was formed in 1867, it just didn't mean an amalgamation of the lower and upper Canada, but it actually meant the implementation of white supremacy and genocide of Indigenous peoples. I think that what we heard today speaks to the value and importance of Indigenous midwifery and of the trust, caring, and evidence-based. I'm using this Western language because no one can argue with the outcomes that Brenda shared. No one at all. And if they do, I wonder why. So I encourage each of you to please ask questions. Now back to this history. In 1892, the government of Canada specifically hired two obstetricians, a husband and wife team, to provide obstetrical services and maternity care on reserves in southwestern Ontario. It is at that point that the government of Canada, along with physicians, along with nurse midwives, began to interfere, interrupt, and eradicate Indigenous midwifery, as well as other Indigenous healing practices, providers, and medicines. In some ways, not in some ways, this was further implemented through various aspects of the Indian Act in 1876 and its various amendments, not just with residential school, but also making the health practices of Indigenous peoples illegal, along with the reserve system, which separated Indigenous people from each other. These reserve system prevented the traveling of healthcare providers and medicines and support peoples to those who lived on reserves. How have things changed? As Brenda has spoken to, the evacuation policy is not very much spoken about, aside from those who study it like I do, or those who work within it. But why is all the maternity care services, why are they located in the South? Why are they in urban settings? Why are routine pregnancies, healthy pregnancies being evacuated routinely to a hospital, to a level 3, A, B, or C hospital. This does not make sense. It is not a wise use of our resources. And it seems to me a purposeful intention to discredit and ensure that Indigenous midwifery does not thrive. So why are Indigenous midwives being limited? There's a systemic limitation within all of our healthcare systems, federal, provincial, and territorial, that prevents Indigenous midwifery from thriving. This is unacceptable. We must call to this and eradicate this. This is about equity. This is about making the wrong things right, because that we don't have birthing centers in all our communities, and that our Indigenous midwifery numbers across the country are not thriving. This is systemic oppression. This is white supremacy in action. In fact, I argue that interfering with Indigenous birthing knowledge and birth workers, and I'm speaking to the knowledge that Vanda shared today, as well as birth workers such as Brenda, is a direct act of white supremacy and genocide. So if you don't support the knowledge of Indigenous people, birthing people, or Indigenous midwives, you are contributing directly to the ongoing maintenance of white supremacy and genocide of our peoples. I just want to see where my time is. I'm about halfway through. So there's a systemic exclusion, oppression, and discrimination of Indigenous peoples in this country that can be quite pinpointed to the Indian Act of 1896. This, of course, is only one piece of extraordinary legislation that does limit our lives in many, many different ways. But there are also ways that other Indigenous peoples in this country have their lives limited, either through no recognition at all or very limited recognition with systemic underfunding, under-resourcing. It is really important that you understand the historical context of this country, how it came to be a nation state, because all of it affects the health and wellness of Indigenous peoples, and in fact, everyone in this country. Healthcare professionals that came from Europe supplanted Indigenous ways of knowing of health and wellness. But it is clear something is not working. Today I was giving a class to a third-year group of students, and there was about 8 students that remained near the end. Every single person told a story of their encounter with a healthcare system, not just the emergency room, but other care providers who completely dismissed them, and they almost died. And I think this is not working for anyone. Why are we sustaining it? Why are we not #pivoting? Why are we not reallocating resources to those who actually want to work? I also wonder about the governance of healthcare workers in terms of scopes of practice. Midwives often, registered midwives often have their full scopes of practice, which are regulated at the provincial and territorial levels. Why are they being limited? And who's doing that limiting? I don't understand a lot of this, but how is it that the head OB can decide whether or not there are 5 midwives working at the hospital and not 10? Why is the obstetrical unit and that governance within that hospital able to say what a midwife can do or can't do despite her training? This goes for also nurses and nurse practitioners and family physicians. So there is something really not working for everyone. And I think that the joy that we heard near the end of Vanda's presentation really can speak to the way things can be changed and shifted very quickly should there be a desire. And I'm so proud of my colleagues that were part of that birth. Some of you may be here because I know you're awesome and we need you. So I wonder about this idea of evidence-based care, because care providers in the Western world are often not providing care that is evidence-based, despite advocating for it, so they can maintain their leadership within the healthcare systems. And I feel frustrated with this, because you can hear the changes that can happen quickly once people realize that their care was substandard, in fact, quite disgusting. And I wish that those healthcare providers who treated Vanda so poorly and her family would be able to come to terms, apologize, and make reparations to her. She deserves it, as does her family. So I need you all, please, as Brenda shared, she's living the change. And I will ask you, are you living the change? Miigwech.
Thank you so much, Karen, and for reminding us about the importance of understanding historical and contemporary context and systems and structures, and including birth evacuation policy, and really the responsibility that we all have to understand these things better. I appreciate you sharing with us today. I've got 15 minutes, and so going to go to question and answer. As I mentioned, thanks to those who did submit questions in advance. If you want to hang out on camera, Karen, that's great. You're welcome to join us. I'm going to go to Vanda first with a question. Let me just pull up the right screen for myself. So Vanda, hi. Hoping you can share with us what culturally competent care looks like from the client perspective, especially during COVID limitations.
Thank you for the question, Nicole. I think one of the crucial elements in culturally competent care is showing the client that you are comfortable with difference through attitudes, actions, and body language. For many people, difference makes them uncomfortable, and that's easy to pick up on. Culturally competent care for the client is also having a primary care provider who understands that worldviews and practices are unique across Indigenous nations, as are the experiences within communities, families, home, urban, rural, and remote. There are levels of personal interpretation too. Some clients lean towards traditional protocols, while others adopt a cultural revival approach. But however they express their cultural agency, it's important that it's received non-judgmentally. Your client might have a deep mistrust of Western medical systems from negative experiences in the past and intergenerational colonization. Securing prior knowledge about Canada's colonial history and how that affects local Indigenous people and communities shows your clients that you are committed to having genuine relationships with the populations you serve. Making your client feel like they are among their peers is important, which can be even trickier with COVID. Depending on the capacity of your institution, Indigenous patient navigators can play a valuable role. Ideally, they are well supported with knowledge of and networks to elders, knowledge keepers, ceremonies, community organizations, and cultural programs focused on maternal and newborn health for Indigenous families. The client can connect virtually, provided they have access to internet, phone, and a computer. In relation to fostering feelings of safety and respect, get to know your local Indigenous doulas. When the pandemic hit, they were some of the first health support workers to shift to a FaceTime or on-screen platform. If mom's birth plan included the presence of relatives, not having them there would be a tremendous letdown, and the presence of a doula could help. Show them that as an option and that you can work collaboratively. You can even suggest your client support person do the training, as many programs are now offered virtually and accessible where it wasn't before, even possibly through another region. Culturally competent care could also be expressed by encouraging the client to claim their sense of home through family, community, and nation narratives about birthing and midwifery. This doesn't have to be structured through group work or programming, but instead a personal creative production that shapes up as a photo album, a scrapbook, a collage, an iPhone video, photo voice, poetry, newsletter, wellness bundle, and even a bedroom. Finally, don't forget to document your own process and growth around culturally competent care. You can share these memories with your clients, and it allows you to reflect on what worked well and how different initiatives were received. As you move reconciliation into action, it will be part of your institutional memory in the years that follow. I'll also share a few resources in the chat box here. I hope that answers the question. Thank you so much.
Thanks so much, Vanda, and thank you for the mention of doulas. I encourage everybody on this call to do a bit of looking into the power of doulas, and particularly Indigenous doulas. And there's some really great evidence supporting how much they can improve both outcomes and experiences for moms and babies. The next question, and unfortunately we're working through some connection issues with Brenda, but I was able to share this question with her in advance, and she did send us a response recording. So I asked her to talk about the use of digital technologies, which is especially relevant given that we have been working through those challenges with Brenda. So asked her to speak to the use of digital technologies in maternity care in her context.
In general, on a day-to-day basis, we have access to Doulas to listen to baby's heartbeats. Some midwives have ultrasound training to confirm the baby's position or perform a biological profile to ensure the baby is doing well inside the womb. We have access to external fetal monitoring systems that measure the heart rate continually in conjunction with heart rate patterns. In some communities, midwives use electronic patient records that make it easy to document visits in the home, at the clinic, or in the hospital seamlessly. What we do need is cross-jurisdictional compatibility and sharing to ensure seamless patient transfers when people leave or return to the community. COVID has increased access to professional development training over the internet. However, bandwidth issues are real in the north. Many people do not have access to high-speed internet. This is why I am speaking with you on the phone. Hopefully that will change in December. Fiber optic is being worked on in the north. Digital prosperity for all is important because broadband can deliver health and equity to all communities to have access. Broadband is so influential on society that is considered an essential infrastructure, particularly during a global pandemic. These physical networks directly and indirectly affect a wide range of conditions that impact health and life outcomes, known as a social determinant of health. We need regulation and public policy to support every Canadian community, particularly rural and remote, to have equitable access and the skills to use it. Thank you, Nicole, and thank you, Vanta, for your
My thanks again to Brenda for submitting that in advance, and so relevant always, but particularly now in the pandemic. Karen, wondering if I could call on you. We've just got a few minutes left and I've got a hefty question for you. So apologies for the huge size of the question and the small size of the time, but the question for you was, what are the outcome measures for this important work? Karen is muted.
I was muted. I think this is a very good question because it's not for me to say. It's for Indigenous peoples to say what is their outcomes that they would like to have. And this means meaningful dialogue, meaningful, not like, oh, hey, we're going to do a study and if you're happy or not. And I got my CHR grant, got $3 million to do this, and I have 10 grad students, but really, what does the community want? It does need to be community led. And I do think that Indigenous midwives should be or our position currently to be the leaders in these. My understanding, and of course I don't speak for all Indigenous midwives, is that they are there to help and to assist people understand where they're at and what they would like within the current context, and how can we dream and vision for more of our health, more of our wellness, more of our family, more of the things that keep us healthy and well, like clean water and land. Their climate change is an issue that is directly related to the health and wellness, maternal child health and wellness of Indigenous peoples. These are broader societal issues that are being, the burden of which on marginalized people, of which Indigenous people are marginalized. One of the things that I was speaking to before was about evidence-based medicine or practice. I think that we must trust the experiences that are shared with us. They do not need to be legitimized or validated through some type of scientific process, because science is biased. Science reflects a white, male, privileged voice within the academy. This is quite obvious when you look at the publication rates of who gets to publish and who doesn't, who gets tenure, who doesn't. We are still marginalized the science and the evidence that is being produced. We know as healthcare providers, for those of you who work in healthcare, or those of you who've had a healthcare experience, you are the experts on yourselves. Healthcare service providers are service providers. We provide a service and we need to act as such. And I speak not just to the physicians and nurses, but also to the midwives. It seems that Indigenous midwives are the only group to uphold this. And of course, not to, I saw some comments in the chat, not just to those who are doing the good work, but as a system, we need healthcare providers to do the service that they are tasked to doing.
I have the stickiest video button all day. I don't know what's happening. Thank you so much, Karen. And with 4 minutes left, my apologies to those who have submitted questions through the chat. I'm afraid we're not going to get to more of them. However, I believe a slide is going to appear any minute now. The folks that we've been working with at the National Aboriginal Council of Midwives did share some resources and promising practices. Here we go. And everyone who's participated today will get a follow-up note after, and the slides will be shared with you. So I encourage you to visit the National Aboriginal Council of Midwives website and to look at the resources that were shared by Vanda and Karen and maybe others, because I'm not super great at monitoring a chat and talking at the same time, but look in the chat for other resources. And then also promising practices that I encourage folks to check out, and hope that some of those additional questions might be answered there. If we can go to the next slide. In concluding today's session, we wanted to mention the heart of healthcare. So recognizing the unique power of art, the heart of healthcare is a virtual art gallery which aims to bring awareness about patient safety, explore the impact of preventable harm, and inspire healing in action. And Patients for Patient Safety Canada has sponsored a new exhibition in this gallery focused on safe maternal and newborn care, which includes over 70 submissions in various media, including paintings, fiber art, poetry, stories, sculpture, dance, and music from professional and amateur artists. And we're going to post the link in the chat and really encourage you to visit that and check out the beautiful artwork that was submitted. And so I'm hoping someone's going to post that in the chat. So with that, I will say miigwech and thanks to everybody for participating today. My deepest gratitude and thanks to Vanda, to Brenda, and to Karen for being here and contributing your knowledge and experience and bringing awareness to this incredibly important topic that, as I said from the get-go, is so near and dear to my heart and to my family's experience. So thank you all and have a great rest of the day and a great weekend. And for those like me who just survived their first week of back to school, congratulations.